Well, it's my great pleasure now to invite Dr. Rad Rogani again to give the symposium by Roche. Dr. Rad has been introduced initially, so the floor is yours, Dr. Rad.
Thank you, Dr. Jassim, for the kind introduction, and also thank you, Roche, for the invitation. So I'm going to talk about mainly ocrelizumab, especially with the long-term data we have. First of all, I think we all agree that there is a shift in focus to disease progression. We always talk about relapsing remitting with the also association of MRI inflammatory changes. But in the era where 2000 and on, we are seeing more disability because we are seeing more progressive cases. So today, our shift is actually to halt disease progression, not to halt just the inflammation. And conventionally, we always separate the relapsing form from progressive form, and we separate PPMS from SPMS. But I think with time, especially with the new phenotype classification with Lublin, we see lots of overlap between SPMS and PPMS. And I don't think we can easily sometimes isolate PPMS. Even when you go back on the PPMS patient and ask few questions, you will see there is some improvement in initial symptoms suggestive of either a mild relapse or some inflammatory component. So this SPMS, PPMS are lumped as a progressive MS by Lublin. And this probably will tell us also that maybe we're going to use the treatment of SPMS and PPMS together for the same kind of pathogenesis. Also, the big issue with all MS experts is when to diagnose SPMS. And I think the transition from relapsing to progressive course is not easy sometimes. It's usually very silent and very slow. And there is always a delay in diagnosing SPMS. We continue using the inflammatory drugs for a relapsing form until late, even with high efficacy medication. But at the end, I think we have to break the ice and tell the patient, you are now in SPMS. And this is a big difference when we talk about treatment. Now, acute and chronic disease activity has been described in the last few years, especially pathologically. We know in acute phases with the relapse or early relapsing course, you will see lots of active lesions, especially with the MRI. With the disease progression, you're not going to see activity with gadolinium or new lesions. You will see silent lesions. Under the microscope, you may see chronic inflammation in the leptomeninges. And you will see also some smoldering plaques. And when you look at the MRI, you don't see any change. Sometimes you always see this normal appearing lesions, or what we call dirty white lesions. So overall, if you look at the actual brain volume, you will see it is lower than usual. So there is generalized atrophy, and also there is a focal atrophy. Now, this is a big issue when we talk about progression. Some of the patients may have a relapse and then have accumulated disability. Some patients may come with new symptoms or worsening symptoms. You give them steroids and they don't improve. And you don't know, is this truly secondary progressive course? Or this is maybe a delayed response from the relapse. And I think this is an important concept we have to think about. Is there is a patient with a relapse a disability after relapse, accumulation of disability, and there is also a disability that comes without a relapse. And here is probably the start of the progressive form. So we always need to know whether the accumulation of disability is from a relapse or not. And that's what we call PIRA. PIRA is a definition where there is a progression through certain parameters independent of relapse activity. In comparison to a worsening after a relapse, what we call it relapse-associated worsening. There's a big difference. Why? Probably if we see a relapse after worsening after relapse, you're probably still going into the inflammatory course. But if you see progression independent of any relapse, what PIRA is, you are probably entering the secondary progressive course. So we think MS is a continuum, and when a patient has a relapse or a suspicion of a relapse, you always have to think whether the patient is still in the relapsing course or the progressive course. This is a cartoon just to show you what's the difference between the PIRA and the relapse associated worsening RAW. So after any relapse, usually in early phase, you will have a complete recovery from a relapse. When the disease progresses, especially after 10 years, patient may have a relapse. You give a steroid, you want to see a response of 70–80%. You still have a mild disability accumulation. This is what we call relapse associated worsening. If a patient continue and have more disability, so 6 months later, 1 year later, you see the EDSS went from 4 to 4.5 or 5, and there is no relapse after rebasing the disability after the last relapse, then you are talking about progression, and this is PIRA. And it's always need to wait at least 30 days from the relapse before you rebase your clinical parameters. Now, the clinical parameters that we need to rebase, you can use whatever you want, but classically in the clinic, we use EDSS. So if there is an increase of 1 point in a patient with EDSS 6 or less, this is considered progression, sustained for 3 months. If a patient has EDSS 6.5 or above, 0.5 is actually very sufficient. It's accumulating over 3 months. And 6 months, maybe this is more accurate. Or sometimes you use the 9-hole peg test for the upper extremity. If there is a 20% increase in the disability, this is considered progression. Also the 25-foot walk, if there is an increase in 20%, again, you consider this a progression. So PIRA depends on your measurement and also rebasing from the last relapse, and at least you have 30 days from the relapse and at least sustained progression over 3 months. So if you have these factors, you are here talking about PIRA, which is a progression. And when you look at even if you go to your patient in your clinics and you try to get those patients who have insidious worsening of disability, you will find there are some patients are really secondary progressive, but we are still treating them as relapsing remitting. So probably we are delaying the diagnosis because previously we did not have any treatment, but nowadays I think we have to think this, especially if the patient are on low efficacy medication or medium efficacy medication. So is this progression truly silent, or we are not doing our job in detecting these parameters? Are we doing the actual test with the 9-hole peg test or the 25-foot walk, or doing a neuropsychiatric battery? Sometimes it's cognitive also may tell you, yes, the patient is progressing over time. We always focus on short-term parameters, but I think overall we have to think outside the box. The long-term progression is very important, especially in patients who are on a medication and you are still hesitant to say whether this is an effective or not effective. If a patient is progressing with no relapses, sure, probably you're not doing the right thing. We are suppressing the relapse, and this is what the medication is doing. But if we are not preventing or delaying the progression, you probably need to think about changing the treatment. There is always window of opportunity. We all agree with this. You have to keep this in mind. Patient quality of life might be very important, especially once you reach the cane or the wheelchair. Here is probably the dependency on others will put a burden on not just the patient, but even on the country and the budget overall. So not thinking just short-term activity, we have to think about the long-term disease progression. And this is the objective of any treatment nowadays. As I said before in my previous presentation, we previously focused on suppressing relapses and focusing about annualized relapse rate in the clinical trials. And I think with time, you will see that the disease progression probably going to be the main outcome in most of the trials. We have high efficacy medication with acceptable benefit risk profile. Nowadays, I think when we talked about, even previously in my presentation, we talked about the high efficacy medication. We have at least 4 or 5 of them right now. We will get another 2 in the next year or so. So you have the choice, either keep it in your pocket and save it for later in case it's needed, which is not recommended, but use it as early, especially if there is a window of opportunity, especially in those patients who are started to accumulate some disability. And there is evidence that the patients who were on early intensive therapy with high efficacy have delay in disability progression over time, compared to those who use the classical escalation approach. When we fail one treatment, go to second treatment. So there is a difference, even tested in post-marketing studies. And again, with another study from the MS base also tell us, even from the beginning, patients who were on platform therapy had more risk of progression to SPMS compared to those who were started on high efficacy therapy from the beginning. So there is some evidence to hit the disease very hard. And I don't want to put more stress on this. We've seen in the last also 10 years an increase in the use of high efficacy medication, probably because they are available. And also, I think it's more important, there is more MS experts nowadays, there's more MS centers, and also the education of general neurologists has increased greatly in the use with the adoption of high efficacy medication. And I think we all satisfied probably that more use of high efficacy in highly active or aggressive patient is probably a must nowadays. We cannot deny patients from high efficacy medication, especially if they need it early on. And there is no role of first-line medication in those such aggressive patients. And all of this, we are trying to save the patient from the burden of MS. Quality of life goes down with ADSS. Even if you reach 5, you will see a reduction in quality of life for around 40%. But once a patient achieves 7 or 8, probably it's done. The quality of life is actually very, very low. So we have a drug that's been approved for both relapsing remitting and primary progressive MS, which has data for more than 6 years nowadays. And this is the long-term data is very important, and we always look for the long-term data because it's a safety data and also to tell us whether the drug is sustained over time. And you all know the OPERA trials where ocrelizumab was compared to Rebif in over 2 years, and there was a significant reduction in the MRI lesion. And you can see the long-term data 3 years after the trial shows a sustained suppression of MRI data. Also, this is the more important, I think this is the trial, the 22% risk reduction in the composite of PIRA, 12-week PIRA. So the progression independent of relapse activity, you can see that when compared to Rebif, there is a significant reduction. But it's more important to see it over time. It is sustained even in patients who were switched back from Rebif to ocrelizumab. You can see the gap. There is still a difference. So starting early is very important. Trying to shift to another drug is not going to bring it back to the baseline. And this disability improvement was a new concept introduced in the last 5 years, and all drugs now trying to see whether there is an improvement. I'm sure we all see the improvement in the first 2 years with any medication. Partly there is some steroid effect, sure, but I think overall the ADSS sustained over time. And I think with the annualized relapse rate, this is the year 4 data, again shows a sustained effect with ocrelizumab, whether in a patient who were already on ocrelizumab initially or switched from rebif. So overall, I think the efficacy data has no question with the sustainability. It's important to look at also the PPMS open label extension. We have additional 3.5 year, over 450 patients continued the open label extension. Again, we see the sustained delay in time to wheelchair, which is ADSS-7. So now we are talking about over 6 years from the initial initiation of the trial till the last point of observation. You can see the sustained reduction in progression for the 24 weeks or the 3 months progression. Again, you can see it's actually not just sustained, but probably lowering the risk over time. So when we talk to a patient, what's the time to ADSS-7? In a placebo, usually 12 years in patient with PPMS. With ocrelizumab, we are trying to delay it. So average delay is between 5 to 7 years in achieving ADSS-7 in PPMS patients. I think we always need to talk about safety also for the long-term data, especially in open extensions. This is the 6-year safety data across all the trials for the relapsing and the PPMS trials, and also for the open label extension. We don't see any red flags so far with ocrelizumab in terms of infections, malignancies, and serious infections. Even the discontinuation rate in the long-term data showed no red flags. So I think overall we see a good safety data supporting the the 2 pivotal trials. Just for those who start using ocrelizumab, the dose is usually every 6 months with 600 milligram. However, the first dose has to be separated, divided into 2 doses with 2 weeks apart, 300 milligram on day 1, and then in day 15, another 300 milligram. You don't need to do any monitoring. You don't need to screen for JC virus. There is a protocol that's available in hospital where you may need to use IV silomidrol and antihistamine for infusion reactions. As of January 2021, over 200,000 patients being treated with ocrelizumab globally. We built a good also cohort in Kuwait with a good satisfaction in both relapsing remitting and PPMS patients in Kuwait. We do use it sometimes with SPMS and I showed you previously in the presentation, both ECTRIMS and MINACTRIMS endorse the use of ocrelizumab as off-label for secondary progressive, especially if you label them as Dublin indicated. This is all progressive, probably with the same mechanism. With this, I'll thank you for your attention, and I'm happy to receive any questions.
Very much, Dr. Raed, for this excellent presentation for this evolving drug, ocrelizumab, and new data. on this. I have received one question for you, Dr. Raed, which is any other biomarker you can use for the progression of multiple sclerosis apart from the EDSS? Is there any other biomarker you can use, biochemical biomarker you can use for these patients?
Thank you, Jasper. This is a good question. Unfortunately, there is no high specific biomarker. And neurofilaments being developed to try to assess the progression, but actually it's a measure of axonal loss. So if a patient had a relapse, severe relapse, you will see an increase in neurofilament. Patient is progressing and shedding more axons, you will see an increase in neurofilament. I don't think even it's a good additional marker to your clinical judgment. Sure, the neurofilament, it's probably when you attach it to your clinical judgment, you're probably going to have a better answer without, I mean, it's a supporting evidence. I think your clinical judgment is at the end is where you're going to say this is progressive course or not. You need to have a sustained progression. So you think a patient is progressing, bring him after 3 months or 6 months, and you will see this progression still there or getting worse. Some people may use the steroid trial as to see whether there is a superimposed relapse. And third, and I think this is more important, look at the history. Patient passed 10 years of disease duration, passing the age of 35 or 40, you are probably talking about a progression here. And also look at what medication you are using. If you are delaying all the high efficacy, probably the patient is progressing. We are always shy from telling the patient you are progressing, but it's a fact. We have to, at one time, break the bullet.
Thank you very much, Dr. Raed.